frontal lobe dementia, which is where the centers for judgment lie. Or you could have a person who has a prominent symptom of movement problems that may indicate Parkinsonism. So there are different types of dementia. I think I'm going ahead. There we go. So most of the time, the careful clinical history will really tell us the answer of what's causing dementia. We will do that with a physical exam in our medical office to look for other causes of memory changes. We can do simple memory screens like asking someone to draw a clock, which is actually a pretty complicated task because you have to have spatial ability and recognize the numbers, the concept of time, and often that's the first test that starts to change. We'll order blood work for people to rule out things like vitamin deficiencies or thyroid conditions, or in rare events, you may have neurosyphilis, where a person has an actual brain infection recurring from a latent infection from many years ago. So blood work helps rule out some causes. We order a brain MRI, which helps us look for a stroke or a mass, or for the overproduction of spinal fluid in the brain, which is known as hydrocephalus and is a very treatable condition. And the last step is ordering a formal neuropsychiatry test from a psychologist. And that is the test that will give us the most definitive diagnosis about what type of dementia is present. These are the steps that shine light on whether we have delirium, something reversible, or dementia. But what next? Once that process is done, a mentor of mine used to say that elders are like onions. You have to peel them back layer by layer. I like to think of my work more as like flying an airplane. So we think of our bodies like the cockpit of an airplane. And as caregivers, we can step in as a co-pilot for someone and help them look at the cockpit for gauges, indicators that something isn't right. So we can look for things like when we have an elder with cognitive impairment or dementia and we notice a change in their usual behaviors, we'll look for, are there medical conditions? Are there sensory changes? You know, sometimes people will express what looks like a hallucination, but they may actually have cataracts or vision problems that are creating an image they don't understand how to interpret. Maybe they need an eye exam. Maybe they're hearing things, but they really need a hearing test and a hearing aid. So there are sensory things we can address to improve the quality of their life. Is there something in the environment going on that's triggering a behavior change? Maybe it's too hot or too cold, making someone irritable. Maybe it's too cluttered. I feel like that at my house sometimes. I have teenagers. You know, maybe it's too new. A classic story is one of my patients, you know, may bring their parent in because their parent lives in California, comes to Atlanta. They're normally cognitively intact and are now totally confused because the change in environment can trigger an episode of delirium. So sometimes you might have a mild dementia, but also have delirium. These are the things we look for. Are there fall hazards or safety hazards in the home that might be creating discomfort? Are they getting enough nutrition and hydration? Are they having normal bowel or bladder function, or do they need treatment for constipation or some other problem? Are they over-medicated? We see that a lot. Do we need to reduce or trial off some medications? Are there any signs of infection or pain? Uncontrolled pain can just manifest as forgetfulness, confusion, or irritability. So maybe we can use topical pain relief or physical therapy to help people be more comfortable and therefore more calm. Are they having anxiety or depression that we can address for them? Or sometimes depression in elders doesn't look like sadness or tearfulness, but it looks like apathy, just the lack of initiative, lack of motivation. And so we tease out, is that a symptom of depression or is it dementia itself? And lastly, one of those layers is social supports. Are they getting engaged during the day? Do they have a place where they can have meaningful conversations and interactions? That is the many layered approach to geriatric medicine and to caring for people with dementia. So once we've read those gauges, checking for those things, we ask ourselves, now what can we do to address them? How can we turn the dials to help improve their quality of life? I think of that as looking at tools in our toolbox and listed from what I would say the least important to the most important. First, I think of we have medications that we can sometimes use. So judicious use of medications, especially in people with anxiety or depression, sometimes medications can help with those symptoms. We have a few medications available that can help slow the progression of dementia. You'll often see those marketed on television. That's something that can be discussed with your physician. There are medicines to stabilize mood. And in the case of a person with hallucinations, delusions, what we call psychotic symptoms, there are medications for those things as well. So number one, are there any medications that are needed? Number two, have we addressed the layers of the onion? Because often that will correct many of the underlying symptoms. And I guess I'm doing them backwards, but number one, because I think it's really the most important, is assembling a team for this person. Because as you can see with all these layers, it really takes a team of people. Maybe this person would benefit from physical therapy to help with pain relief, from occupational therapy to help be creative about tasks they can do. If someone was always the doer, maybe they need, maybe you can give them towels to fold or give them little tasks that are simple that they can even do over and over that might help give them a little purpose. Recreational therapists, lots of people, Mary will talk about this, specialize in how to engage people with cognitive impairment. Your nurses, doctors, home health, sometimes specialty care like neurology or psychiatry is needed. So most important, we want to assemble a team of support for your loved one. So as we look at the turbulence of dementia and think about providing care, we can just circle back to these steps. Every time there's a new challenge or new problem, number one, recognizing the brain does many things for us besides just memory. Number two, have we identified the cause of the dementia? Number three, have we looked at all the layers of the situation and addressed them one by one for using those tools in our toolbox? And number five, bringing in a team to help you. And with that, I'll transition to Mary Caldwell, who will talk more about building your team and caring for your loved one.
Thanks, Melissa. You're welcome.
Well, I'll come this way. It's easy. I don't have to high step over the wire.
Yes, please.
Good evening, everybody. My name is Mary Caldwell. I'm the director here and a gerontologist. Nice to see you. So I guess I'll just click this. But whoops. How do I go back? Can you help me with that?
Forward and back arrows, I think.
Oh, okay. All right. So it is really important to think about a care team and a plan of care upon diagnosis. This is something that almost never happens, and I hate that for folks. But it's necessary. It's a hard diagnosis to hear. There's almost always a shutdown. Nobody wants to hear that. I talk about the folks that I meet who've just been diagnosed, and it's the general patient, the general dyad, that's a care partner, and the person that has a diagnosis, that's the dyad. It just means two people. Generally, you're looking at someone in their 70s, although people are diagnosed before age 65. That's called younger onset, or, later in the 80s. Really, there's not an age limit to when one can be diagnosed, unfortunately. But when a person is diagnosed, generally they are in their 70s, either about ready to be retired or, or already are retired, and they have big plans for the golden years with their partner. And to receive this diagnosis can be just devastating, mainly because there's not much known about it. And I will say that I think if you live in the metro Atlanta area, there are many, many resources. So we're lucky for that. But it's important to be proactive, not reactive, you know. I think early education and acknowledgement of the diagnosis is essential. If you cannot accept the diagnosis, you can't accept the diagnosis if you don't know what the diagnosis is. There's lots of stigma surrounding Alzheimer's and related dementias. The stigma, and just I'm going to speak plain with you because that is my practice to speak plain. So I mean no disrespect. I don't like the stigma, but the stigma is a very old person sitting in a corner, kind of drooling and not knowing anything. That is not Alzheimer's today in 2023. People are being diagnosed, thankfully, much, much earlier. We have better diagnostics. Cognitive neurologists know this disease better, unfortunately, because we have so many people with it, but we've got a lot of research going, and so it's easier to diagnose. That gives us the opportunity to do this early education, what is dementia, and acknowledge and accept the diagnosis, both the care partner and the person with dementia. I think it's essential. This empowers a person living with dementia, to just understand the disease better. It increases self-determination and quality of life but that's about accepting, and then moving. I think acceptance is not something that, okay, we're processing this. Now we've processed it. Great. It doesn't work like that. You're processing and accepting every day. The care partner is, and the person with the disease is also processing and accepting every day. One of the most common, and I would say first symptoms of dementia is a lack of self-awareness. So at some point, because your short-term memory is needed to be self-aware. So at some point, the person with dementia, most likely, unless it's some, look, what is the old adage? If you've seen one person with dementia, if you've met one person with dementia, you've met one person with dementia. Consistently inconsistent and different from person to person. I mean, it's a neurological disease. We all learn differently. We grow differently. So the unraveling of that will also be different for every person. But the fact being that the person with the disease will at some point lose self-awareness, and it becomes, what are you talking about? Me? I don't have a problem. You're the one with the problem, or something along those lines. But if you've done the work, this early diagnosis and early education and acknowledgement allows the person who is living with the disease to make very important decisions about what kind of care they see themselves as wanting. They can direct their care and say what they want and make decisions with the care partner, that the care partner can then have confidence that in the future, when the person is not able to make their own decisions, they're acting on their behalf. That's very important and an essential part of this. It lessens the burden for both members of the dyad, because this disease brings with it a lot of constant chronic stress reaction, hypervigilance. The care partners are worried, what if I get sick? What if I require surgery or need to travel? What will my person do? That's the chronic stress that kills. When we're raising children, when we're caring for others, even when we are away from them and with other people and active within the moment, there's a little part of our brain that is on the child or on the husband or the spouse or the person that we're caring for. And that's what I mean by chronic stress. That raises cortisol levels, right, Dr. Black? That's not good for you, and it doesn't help, So this is a reason that we want to be proactive. Also, if you're not, that chronic stress that just weighs on your shoulders can literally feel heavy sometimes. And it brings with it grief, anger, impatience, frustration. This will happen also with the person with dementia. I mean, this may be the first time you've heard it, but believe it or not, people with dementia have feelings and emotions and thoughts and dreams and imagination and curiosity. And we have to honor that whole person. So I see a huge difference in the course of the disease for people who have this early intervention of education and help with a care plan and knowing about a care team. So that was a large part, but I think it's important for people to know why it's important, because what do you want to do? What's the natural reaction when you hear bad news?
Yep.
Or that this is not happening, not me. So professionals like me and like Dr. Black and many of the other professionals in this room, we have a heart for it and we can help you walk through that. Natasha said today that someone said to her, it's hard. It is hard, but we can do hard things, especially if we know that we're going to, have those wonderful, to still have joy and love in our lives, even living with, a bad disease. Okay. So who's on a care team and what is a care team? It may sound like a foreign term to you, but a care team should include, I say, on your care team, you want to include anyone that you would like to maintain a relationship with. Now, on this care team, I'm not talking about your clinical care team. Your clinical care team looks like your primary care physician and your neurologist. I talk to so many couples or families who say, I see them having a relationship with their primary care physician and their neurologist, but never the twain shall meet. You don't have to do that. You can have your primary care physician have a consult with your neurologist even. You can request that. I know a lot of Dr. Law's patients, and they do that very thing, and Dr. Law is happy to do that. I'm sure Dr. Black does this. It just helps because primary care physicians, by and large, are not they're not cognitive neurologists. So it helps very much for them to be able to talk to one another and have a unified care. So that's where your clinical care team begins, is being able to talk to your primary care physician and your neurologist about anything that may come up. I'm talking about, on this slide, your care team of humans that are your relatives and your friends, because it's important to do this intentionally. Why? The stigma, believe it or not, the shame. Like some people really believe they've done something wrong and that's why they have dementia, right? We know that's not true, but we're humans and we have these feelings. So it's important, if you want to maintain a relationship with someone, or if your person that is experiencing the disease has a very important relationship in their life, you might want to talk to them and consider keeping in touch with this person, because if you do not, eventually the relationship will, people don't know what to say to someone with dementia. They don't know what to say to the care partner of someone with dementia. So that's why we need to be intentional. I kind of give homework to the families I work with and said, let's make a list, and they'll always think of somebody, oh, so-and-so, but they live in Texas, but we want to maintain a relationship with them. So family members, whether living with you or living across the country, close friends, formal companions, neighbors, or others, you all can read. So I'm not going to read this slide, but it's important to intentionally think about this. And what you're doing is letting them know about the diagnosis in time. I'm not suggesting that you're going to get a diagnosis and then a week later you're going to be, doing all this stuff, making lists. Be kind to yourself. If you know someone that gets this diagnosis, be kind to them. We have to give ourselves time, but eventually this is important. You have to process. So you want to inform and connect with them often. The co-leaders of the care team are the person living with the diagnosis and the care partner. I will tell you that evidence strongly suggests that it is really the most efficient care, whether it be clinical care or social care, which is clinical care in dementia, I say, and in other diseases too, it's important for the whole clinical team to work together. But one person doesn't get a diagnosis of dementia. 2 people get it, or 3 people get it, or 4 people get it, or a church gets it, or a community gets it. We're all carrying that burden, and we're all really part of a larger care team. But the co-leaders of the team need to include the person with dementia. We want to know their wants, needs, and desires, and what they wish for themselves in the future. You want to provide education for the care team. I suggest to folks, because it is free, because it is evidence-based, the Alzheimer's Association Training and Education Center. I highly recommend that you give it a look. There's the address right there. There are 14 videos that you can watch in the privacy of your home on your laptop. There's early stage, mid stage, late stage. There's what is dementia. There's behavioral and communication. There's scads of education there. And as I say, it's all evidence-based, and it is free. It is a piece of lots of resources, but it's a good place to start. Again, I like the fact that you can do it on your own time, because, this is bringing up emotions. This is emotional. So support and maintain relationships with the care team. And I would be intentional. I've thought of you as a member of the care team because we have been friends for so long. And by care team, I mean, I thought you would want to know that John has been diagnosed, and we will be living with this disease. And we, would like to let you know what's going on. And I would like to support your continuing relationship with John. And I know people don't know much about dementia. So do you have questions? And can I suggest, if you're just curious, here's a website, very intentional about these things, because you're bringing them in. You're going to need those people later on. If you don't do this, what's going to happen is you'll kind of roll along, and then you'll get to a crisis, and then you will realize how isolated that the dyad has become, right? And nobody knows what's going on. So support and maintain those relationships. You can do emails, you can do phone calls. People will ask if they can help immediately. There may not be anything that you need help with immediately. Love us. Support us. Don't be afraid of this disease, please. We love you, and we need our support network. Let's just keep going to dinner. Let's just keep playing golf. Let's just keep doing whatever it is that you do, right? All you have to do is be there. So that takes courage, I think, and bravery. And if you can muster that and do that, it will make the journey way better than if you don't. So another thing that I think is essential in the beginning is to have a daily plan. Now, some people get diagnosed very early and they're in early stage, and I see people live in early stage for years, 5 years, 7 years, even some 10 years. So we're really looking at, yes, I do. Because of the early diagnosis, we think when people are diagnosed that they've probably had the metabolic causation going on for 10 to 15 or years or longer. It's a theory, but it's a vetted theory. So some folks are not going to need a daily plan with everything written out. But look, consistency is good for everyone. A schedule is good for everyone. A sleep schedule is good for everyone with a brain. So some of the stuff I'm telling you is just good for humans and humans with brains, right? So this is even more important when you have dementia, or you are about to go on this journey of walking this road with dementia. it benefits to just consider. Now, if somebody is in a stage where they're starting to have symptoms of dementia, the memory loss, the impaired judgment, and some of the other things, lack of self-awareness, then this is very important to begin to have a daily plan. So it's going to be loose in the beginning, and then your plan is going to get more structured, as the progression goes on. Before you make this plan, you want to consider time management tools. And by that, I mean, do you want an old school notebook? Do you want to put it on the computer somewhere? Do you want to put it on your Apple? Oh, they're trying to give me how many? 5 minutes. Okay, I can do so much in 5 minutes. I've only got one more slide. You want to consider your individual needs. You want to consider the previous routine. Don't change it up at this point. Keep the routine what my person likes and what they're used to doing, because, it's not like an old dog can't learn new tricks, but it's much easier if we're just considering, we call this person-centered in the professional world. Think about your person and what the previous routine was like. Timing of activities. Let's see, what's something, you want to build. In other words, you're not going to probably go swimming at 9 a.m. unless that's something you've always done. You know what I mean? Think about the timing of activities. At the end of the day, people are tired. So let's not, plan a party for 4 p.m. I know that sounds elementary, but you have to be intentional with these things. And if you are living with or a care partner for someone with dementia, your days of rushing around need to just stop. You do not want to be rushing around with someone with this diagnosis. It's just stressful, So give yourself plenty of time in your schedule if there's a doctor's appointment or if you're going somewhere. I hear a lot of care partners that just get anxious because they're up in the morning trying to help someone get ready for the day and they want it done like this. Just settle down. We're not at McDonald's. It's going to take a minute. The sample of a daily schedule I have here because I thought it would just be helpful. But the important, some important points are with the schedule. You want, again, the person living with dementia to help plan, initiate, and complete the task. Let's keep people as independent as possible for as long as possible. It doesn't matter if things are perfect. If the bed's not made perfect, if the clothes aren't folded perfect, you want your plan to be flexible. Oh my gosh, you will learn flexibility as a care partner. You will learn it or it will kill you. It's just important to kind of be in the moment. So I thank you for coming. That was the last slide. There's so much more. Lots of places in Atlanta that you can get absolutely free, absolutely amazing care consultation, including here at Town Square from me by appointment. So thank you.
We're going to do Q&A. Yes. Services you provide here.
Mm-hmm. Okay, so Town Square is an adult day center and Alzheimer's Resource Center. We provide care from 8:30 until 5.
Does that include personal care?
Some, yes. Yes,
Can you give us any tips on how to encourage an elderly to get assessed? They don't want to.
Yeah.
They
You
will
want to
not.
start that? I do it a lot, but if you haven't.
Well,
Dr. Black, can you repeat the question? I'm not sure everybody can hear it.
the question was, how can you encourage someone to get assessed? So I'm a geriatrician and I have this conversation so much. So the number one reason for someone to come to a geriatrician is my daughter made me come. That's why people come to me, mostly. And there's a few other reasons, but that's probably 90% of it. And so at the beginning, people don't have a lot of insight into their symptoms. So convincing them to come for an assessment can be hard. And I'll tell you honestly, what I tell people in the initial visit is it's probably a little bit of a tough love approach, and I don't know if it always works, but what I tell people is, when I do my history and physical for you, I notice that your memory seems a little off, or I understand you're having these symptoms. And I can tell you that once I bring that person into an exam room and the family's on the other side of the door, they almost always admit to it and say, yes, I've noticed it too. Occasionally you have a person with zero insight or denial, but most of the time they'll say yes. And so behind that closed door, what I usually say to people is, it's so important for us to understand early what's going on, like what Mary said. And what I see happen too many times is that people are in denial or they want to wait and see. And what happens is eventually a crisis comes where someone leaves a stove on or a faucet running or wanders from the house or gets lost driving. And it creates a crisis situation. And when you're acting in a crisis, you lose your choices and you lose your options. You may end up in the hospital with an injury, and it's like treat them and street them nowadays. You don't live at the hospital anymore like you used to. So as soon as those vital signs are stable, they want you out. Often people end up in a nursing home for rehab, and the medical care happens very fast. I mean, very fast. And so then the families are left with what next? We never prepared. We never thought about what would happen if we had to bring someone in delirium, because that's what happens, is the dementia flares and then it subsides and it stabilizes for a while and it flares. So I really have that conversation with my patients as early as I can that, in order to prevent that scenario, the best thing we can do is get you assessed early. So you and your caregiver have all these tools. Because usually what motivates my patients is they don't want to be a burden. I hear it so much. They don't want to bother their caregiver or their family member. So I try to convince them that, the way you don't do that is that we bring in the team and we get the early assessment so everyone has that support. So I try to help them understand that by not getting assessed, it actually creates a worse situation, and it makes them lose their choices because they'll be pushed out into the first assisted living available or the first setting that they didn't get a choice in. So it's so much better to think way in advance. Sometimes I even ask my cognitively intact patients, establishing care in geriatric medicine, if you were to develop dementia, have you and couldn't live in your own home for any reason, dementia or otherwise, have you ever thought about where you would go? What place would you stay in? I already have my places all picked out. I'm in them all the time. Like, as soon as I'm old enough, I know where I want to be. So, I try to prepare people even well before their dementia diagnosis, because none of us know if there's anything we learned through COVID, it's that none of us are guaranteed our health next week or next month. So having that plan really helps maintain your independence and your choices.
I will tell you the wrong thing to do. Honey, I've noticed you're forgetting things. I think we need to go have you screened for memory. That does not work. I mean, that just doesn't work. The Medicare, the annual Medicare physical that you have if you have Social Security includes a cognitive screen. So if you're 65 or older and you're on Medicare and you're not getting a cognitive screen every year, then you need to be. Just tell your physician they can charge for it through Medicare. So that's an important thing. Yeah.
And it doesn't hurt to call the doctor's office before your loved one goes in
Ditto.
and say,
That's what you
hey,
do.
we're observing this. They're not going to bring it up. Please do.
That's what you do.
I had that issue, and this is about my mom, and she wouldn't admit to any of it, and we knew it wasn't gonna be the right way to approach it, but we took it as, you're a certain age, everyone gets a baseline, just go
That's
into it.
exactly
Yes.
right. That is
Yeah.
exactly right.
Oh, that's good.
And it was like, no argument, it was just part of the thing.
And it is part of the annual Medicare exam. So.
What are the estimate costs? Is this out of pocket? Is it insurance? Is it Medicare? What in terms of cost?
Are you
What do you
talking
mean?
about town square or the memory
The town
screening?
Square
Town
in terms of the daycare, the services?
No, ma'am, Medicare pays for none of this. It never has, and I wish it would, but no.
So
It
it's
doesn't.
insurance or out of pocket? Is what-
It depends on your long-term care insurance. If you have it, yes, we're private pay. Yeah, I don't know, you want to pick? Go ahead.
It relates back to the question here and your response, Mary, about what not to say. So honesty. Is honesty a good policy as it relates to dealing with your loved one? Do you say, I just told you that 5 minutes ago? And I mean, I know that sounds rude, but so I'm just taking it to the extreme. Where are you honest and where do you kind of couch things?
Nancy Kreisman, who's a social worker, calls it compassionate deception. Sometimes it's okay to just play along if you know you're going to say something that's really anxiety provoking.
Mm-hmm.
No one knows your loved one like you do, right? So
Well, I've told you that before, is truly not helpful.
Yeah, I figured that.
And they know probably that, they have they may know that there's a memory loss. I think that this is a big subject. As I said, it's consistently inconsistent and it's different with everyone. I think if you are dealing with this, it is so important to have a support group because you're going to learn more from your peers. I could talk to you, but every situation is different. And sometimes you just have to have your care team and just talk it out. And, but I mean, care partners get frustrated too. And then what I say to care partners is, believe it or not, the person with a diagnosis, they're sick of you too. They're over you. They need respite.
There's that.
I mean, it is just true.
yes, ma'am.
I'm sort of along that line, is I need to know how honest I need to be with my husband. In other words, he doesn't want his children to know.
Yes,
He doesn't want, even though people notice on their own.
yes.
And for 2 years, I kept it a secret out of respect to him.
Mhm.
And when he says, well, has anybody said anything to you? Well, if I say the children did, then he's gonna get upset, not
Right.
permanently, and say, well, I don't wanna see him.
I would love to say something and then Dr. Blunt.
Go ahead.
So what I'd like, he has every right to be upset. When I find somebody like that, very brittle, my own stepmother said to my sister, if you just told that nurse I had Alzheimer's, I'm gonna be mad at you. And my sister just looked at her and said, well, you have that right. Right? I think this is a problem that gets bigger and bigger and bigger like a snowball when there's not early intervention. Early, let's talk about it. There's grief in there. You need to cry. You need to be despair. You need to have all of that stuff. Life is hard. Natasha, we can do hard things. But when, there's impaired judgment and grandiose thinking and all other kinds of biological and psychological symptoms of dementia, BPSD. So that person can't run the household. That's just dangerous. That person cannot run the house. Someone is going to have to stand up and be in charge. Do it benignly. You can do it with compassion. You can pray and cry to your friends. You can do all the things. But what is not helpful is just to not face the fact. You wouldn't I never compare someone with dementia to a child because they have lived a life and have wisdom and experience. But in some ways, the behavioral techniques that you will use with a person with dementia look like the ones you can pull from when you were raising your children. Sometimes you do what's right and your child will be sad and they will be mad and so will you, but you're not going to let them know that. And you're going to say, I know this hurts. I know it's awful and I know it's sad, but we'll get through it.
Well, that's what I said.
Well, then, it's just, there's just some stuff about this that is hard.
It depends. And I think when I'm in doubt and I don't know how, I just try and think, how would I want to be treated if I was in that person's shoes?
Mhm.
And I knew my loved one was going through this,
Mhm.
you know, try and mentally switch places and, you know, how would you want to be treated? And that's the best we can do for our loved ones, right? Honor and respect them, but say what needs to be said sensitively and kindly.
Well, I went to my first support group a month ago. And I said, you know, I just had to make up where I was going because I wouldn't say I was going to a support group. And the leader said, we call that a fiblet. And it's okay to use fiblet.
Sometimes it's the right thing to do. Yeah, it's a great question.
Yeah.
Thinking about that, I wonder about other triggers that set off the person with dementia. Often I see this with my mom with anything to do with finances. You know, she's very worried about that. And so what do you guys usually say about triggers?
Well, I mean, that's such a big question. And again, I think that's why it's important to be a part of a care team, to have a great primary care physician. It's nice if you know a gerontologist who, you know, you can call up on the phone and just hash it out. But what's going to be right for your mom is going to be not right for someone else, right? So you're going to know best. And a lot of times the question is that caregivers don't feel confident, right, Dr. Blatt? It's, you know, you're thrown into this role where you're in charge of someone's life, what they eat, when they go to the doctor, and it's just a heavy, heavy burden. And you have to be able to control your gut, to trust your gut, but it's something you've never done before. So the more you talk to other care partners, the more you just call that best friend on your care team, the more people you have to consult about it. But then at the end of the day, trust yourself. Your intentions are good. You know your person way better than I do. I actually would have no idea how to talk to your mother about money. I can't talk to my mother about it either, but she's never going to die. And we don't need to worry about it. You know, she's not even going to talk about her funeral. So, you know, and people pay me good money to do this. So I just think it's hilarious. But oh no, we cannot go there. She'll only talk to my brother about that. So each family has its own dynamic.
The child-parent relationship is fraught. And so to take off on the care team, and it helps to have a bad guy sometimes on the care team. That's not you.
Oh, yes.
Okay, so this is what I use this for, neuropsychiatry testing. Okay, so Lori Culp is in my neighborhood. She's a psychologist, and I refer all my neuropsych tests to her, knowing full well that Dr. Culp is probably going to be the bad guy. She's the one that's going to give the definitive diagnosis that this person is not going to want to hear. She's the one that did the extensive testing, neuropsych testing. It's kind of like a grade school exam. Like you do all these different things, read something, listen to something, answer questions. It tests all the parts of your brain and it scores you. And it'll say, what's great about it is it says this person's strengths are A, B, and C. Here's a person who can balance their checkbook, but maybe shouldn't be driving. Or here's a person that really doesn't have dementia at all. They're depressed. I've had one result was the person was faking their symptoms. I mean, it's amazing the variety. But so Dr. Culp administers the test in session 1. At session 2, the person and their caregiver come back and she explains the results and goes into great detail about what are your strengths and what should you be doing for yourself and what are your weaknesses based on how you tested objective data that you should be having someone help you with. So when I hit those finance and driving questions, I'm like, oh, we're going to need a bad guy. And I don't want it to be me because I don't want to get fired. And I don't want it to be the family members, so we can use the neuropsychologist as the bad guy if you can get him in the office. So, but maybe it's somebody else on the team. You know, maybe it's another one of the siblings that's always had a contentious relationship anyway, and they don't care.
Right, I do that
You know,
with my
you shouldn't
mom.
be driving, you know.
I will also bring up the idea that you're not gonna be able to solve every problem. And you know, according to the law in the state of Georgia, you can have dementia for for miles, and unless you have unless you go to court and get guardianship, they can make their own legal decisions, I mean, craziness, I know, but, you do have to have boundaries as a care partner and realize what can be done, what cannot be done. And yeah.
All right, well, we'll hang around after for more questions if people have them.
Thank you. Thank you so much.
Dr.
All right, thank you, everyone. Great discussion, great questions, great information. Just to wrap things up here, thanks to Dr. Black and Mary Caldwell for the presentation. Thank you to Dr. Black for sponsoring this particular program, and to Hardest Buckhead for the food, which I think was pretty good. Yeah, pretty fantastic. And then to Town Square Sandy Springs for letting us